block simulation 2. Same rules, read the command first, scan for buzzwords, build your differential fast, lock in, move on. No going back. New topics, same process. Let's start the clock. Read the command. Primary mechanism of hypokalemia. Hypertension, low renin, high aldosterone. Adrenal nodule, that is primary hyperaldosteronism, Conn syndrome. Aldosterone acts on the principal cells of the collecting duct. It upregulates ENaC-I, the epithelial sodium channel, on the luminal side, and the NACA ATPase on the basolateral side. More sodium reabsorbed, more potassium and hydrogen secreted. The result, hypertension, hypokalemia, metabolic alkalosis. Low renin tells you the aldosterone is autonomous, not driven by the renin-angiotensin system. Choice E is a trap. It says decreased aldosterone-mediated sodium reabsorption, which is the opposite. Aldosterone is Hig here, causing increased sodium reabsorption and potassium loss. Choices B, C, D introduce alternative mechanisms not supported by the clinical picture. Read the command. Expected behavior of this tumor. Ground glass nuclei, nuclear grooves, psammoma bodies. That is the classic pathology of papillary thyroid carcinoma. Papillary thyroid carcinoma is the most common thyroid malignancy. History of radiation is the top risk factor. Cytology is pathognomonic, orphan Annie, eye nuclei, nuclear grooves, intranuclear pseudoinclusions, and psammoma bodies. Calcified concentric rings from slow-growing tumor. Behavior spreads via lymphatics to cervical lymph nodes. Despite nodal spread, 10-year survival exceeds 9-5. PTC is the good cancer. Choices. C and D describe medullary thyroid carcinoma, C cells, calcitonin, diarrhea, ME2. Choice A describes follicular thyroid carcinoma, hematogenous spread to lung and bone, worse prognosis. Choice E, thyroid cancers are typically euthyroid at diagnosis. Read the command. Mechanism of hemolysis. Positive Coombs test, spherocytes, indirect hyperbilirubinemia, mother, O negative, baby A, positive, hemolytic disease of the newborn. Mother is type O. She has naturally occurring anti-A and anti-B antibodies. Some of those are IgG subclass, which can cross the placenta. They coat fetal A positive red cells, leading to extravascular hemolysis, spherocyte formation, and indirect hyperbilirubinemia. Positive direct Coombs confirms antibody on the red cells. Choice D is wrong. ABO incompatibility is mediated by IgG in this context, not IgM. EGM cannot cross the placenta. That is the key distinction. Choice E, R sensitization, is possible in this scenario. Mom is Rh, negative, but requires prior sensitization. First pregnancy with Rh, positive fetus typically does not cause severe hemolysis. The Coombs test and ABO mismatch point to ABO as the primary mechanism here. Read the command. Which structure was injured? This is a laparoscopic cholecystectomy complication, bile leakage, and jaundice. Two things happening. Jaundice means the main biliary drainage is compromised. Bile leak means there is a biliary connection open to the peritoneum. The hepatocystic triangle of Callot is bounded by the cystic duct, the common hepatic duct, and the liver. The right hepatic duct can sometimes run anomalously low and close to the cystic duct, making it vulnerable during laparoscopic cholecystectomy. Transecting the right hepatic duct would explain both findings, jaundice from impaired drainage of the right lobe and bile peritonitis from the open duct. The common bile duct injury would cause more complete jaundice, but the key clue is between the liver and gallbladder wall that localizes to the hepatocystic triangle where the right hepatic duct travels. Choice A, common bile duct, would cause complete obstructive jaundice but lies more inferiorly, not between liver and gallbladder wall. Choice E, cystic artery, will cause bleeding, not bile leak or jaundice. Read the command. Which paraneoplastic syndrome is most commonly associated? Central hilar mass, smoker, intercellular bridges, that is, squamous cell carcinoma of the lung. Squamous cell carcinoma of the lung is the central tumor associated with hypercalcemia of malignancy via PTH-P, parathyroid hormone-related peptide. PTHrP mimics PTH. It activates PTH receptors, increases bone resorption, decreases renal phosphate reabsorption, and raises serum calcium. This is a humoral mechanism, not bony metastasis. Serum PTH is actually low due to feedback suppression. SAID, choice AA, is small cell carcinoma. Ectopic ACTH, choice C, also small cell. Eaton, Lambert, choice D, also small cell, antibodies against VGCCT. The pattern, small cell CTCT, H, ACTH, ACTH, Lambert, Eaton, squamous cell, CGTTH, atingocarcinoma, most common overall. Peripheral, no carcinoma, most common overall, no classic paraneoplastic. Read the command, most appropriate next step. BP158T124, proteinuria, thrombocytopenia, elevated LFTs, schistocytes at 32 weeks, that is HELEP syndrome. HELEP hemolysis, elevated liver enzymes, low platelets, a severe variant of preeclampsia. Management hinges on two pillars: prevent seizures with magnesium sulfate and deliver. Delivery is definitive. At 32 weeks, betamethasone may be given for fetal lung maturity with a 48-hour window, only if the mother is stable. With HELEP this severe. Platelets at 78K, schistocytes, high LFTs. The correct answer is magnesium plus delivery, not expectant management. Choice C is tempting, steroids for fetal lung maturity, but is only correct in mild preeclampsia where you can safely delay. With active HELEP delaying delivery risks maternal hepatic rupture, DIC, and death. Choice A, expectant to 37 weeks, is dangerous here. Read the command. Which drug class caused this? BPH patient, new medication, orthostatic hypotension, fall in systolic BP greater than 20 mmHg upon standing. Alpha-1 adrenergic receptor antagonists, tamsulosin, terazosin, doxazosin, are used in BPH to relax smooth muscle of the prostate and bladder neck. The same alpha-1 blockade and vascular smooth muscle prevents the normal reflex vasoconstriction upon standing. Result: orthostatic hypotension, classic adverse effect, especially in elderly patients. Choice A, 5-alpha reductase inhibitors, finasteride, dutasteride, reduce DHT and prostate volume. They do not cause orthostatic hypotension. Choice C, muscarinic antagonists cause urinary retention and dry mouth, used in overactive bladder, not BPH primarily. Choice D, PDE5 inhibitors can cause hypotension, especially with nitrates. Read the command. Which cellular mechanism drives hypercalcemia? Elevated PTH, hypercalcemia, hypophosphatemia, elevated 1225 vitamin D, hypoechoic neck lesion, primary hyperparathyroidism from parathyroid adenoma. PTH elevates serum calcium through three mechanisms: bone resorption via rank, RANKL, increased renal calcium reabsorption in the distal tubule, and stimulation of 1-alpha hydroxylase in the kidney to convert 25 OHD to 125 OHD calcitriol, which increases intestinal absorption. The most direct mechanism in the bones is RANKL. PTH stimulates osteoblasts to express RANKL, which binds RANKL on osteoclast precursors, driving osteoclast activation and bone resorption. This releases calcium rapidly into the circulation. Choice A describes the intestinal mechanism. Correct but indirect requires 1025 by D as intermediary. Choice D, PTH.P, is made by malignancies, not parathyroid adenomas. The question distinguishes primary hyperparathyroidism, intact PTH elevated from humoral hypercalcemia of malignancy, PTH elevated from humoral hypercalcemia of malignancy, PTH suppressed, PTH.P elevated. Read the command mechanism of immune evasion. Multiple rings per cell, banana-shaped gametocytes, non-enlarged RBCs, Plasmodium falciparum, the most deadly malaria species. P. falciparum expresses PFEMP1, Plasmodium falciparum, erythrocyte membrane protein 1 on the surface of infected red cells. PFEMP1 mediates cytoadherence to endothelial cells, causing microvascular obstruction and rosetting of uninfected RBCs. Critically, P. falciparum has a large repertoire of Vir genes encoding different versions of PFEMP1. It switches expression between variants, antigenic variation, so that by the time the host mounts an antibody response against one variant, the parasite has switched to a new antigen. Choice B describes Mycobacterium tuberculosis, phagolysosome inhibition. Choice A, polysaccharide capsule, encapsulated bacteria like strep pneumo. Choice D, IgA protease, Neisseria, strep pneumo. Choice E, many viruses. These are distinct immune evasion strategies for different pathogens. Read the command, underlying pathologic mechanism. Young patient, prior pharyngitis, new heart failure signs, AV block, murmur, rheumatic fever with carditis versus viral myocarditis. Key, what was the bad cold? The clinical picture fits acute rheumatic carditis. The preceding pharyngitis, specifically Group A, streptococcal pharyngitis, triggers molecular mimicry. Streptococcal M protein antigens share structural homology with cardiac myosin and other sarcomeric proteins. The immune response against the streptococcal antigens cross reacts with cardiac tissue, causing valvular damage, mitral regurgitation, holosystolic murmur at apex, conduction abnormalities, AV block, and myocardial inflammation. This is the Ashkoff body, the pathologic hallmark of rheumatic carditis. Choice B, direct viral invasion, will be viral myocarditis, no preceding strep pharyngitis linkage, no AV block as prominently. Choice C, type 3, hypersensitivity is immune complex deposition, seen in lupus nephritis, post-strep GN, not rheumatic fever. The mechanism of rheumatic fever is type 2, hypersensitivity, cross reactivity, not type 3. Read the command, mechanism of cardiac dysfunction, chronic heavy alcohol use, dilated cardiomyopathy, EF 18%, all chambers dilated, alcoholic cardiomyopathy. Alcohol is metabolized to acetaldehyde by alcohol dehydrogenase. Acetaldehyde is directly cardiotoxic. It damages cardiomyocytes by impairing mitochondrial oxidative phosphorylation, disrupting calcium handling, inhibiting protein synthesis, and promoting reactive oxygen species generation. The result is progressive cardiomyocyte loss and fibrosis, leading to dilated cardiomyocyte loss and fibrosis. Mid-wall late gadolinium enhancement on cardiac MRI distinguishes dilated cardiomyopathy from ischemic cardiomyopathy, where enhancement is subendocardial. Choice E. Thiamine deficiency, Wernicke's, causes high output heart failure with peripheral vasodilation, not dilated low output failure, also called wet beriberi. Peripheral neuropathy plus high output HF, entirely different mechanism from alcoholic cardiomyopathy. Choice A. Pressure overload, causes hypertrophic not dilated pattern. Read the command. Which nerve was injured? Surgical neck of humerus fracture, deltoid atrophy, inability to abduct beyond 15 degrees, sensory loss over lateral shoulder. Axillary nerve territory. The axillary nerve wraps around the surgical neck of the humerus. It innervates the deltoid primary shoulder abductor and teres minor and provides sensory innervation to the lateral shoulder, the regimental badge area. Surgical neck fracture is the classic mechanism. Loss of deltoid function leaves only 0.15 degrees of abduction from supraspinatus. Choice A, radial nerve, is injured at the midshaft. Spiral groove fracture, causing wrist drop, not shoulder abduction loss. Choice D, suprascapular nerve, innervates supraspinatus and infraspinatus. Abduction and external rotation, but no deltoid and no cutaneous territory. Choice E, long thoracic nerve, causes wing scapula. Read the command. Number needed to treat. SGLT2 inhibitor 8%, max. Metformin 12% makes. NNT calculation. Absolute risk reduction equals the control rate minus the treatment rate. 12% minus 8% equals 4% absolute risk reduction. NNT equals 1 divided by ARR. 1 divided by 0.4 equals 25. You would need to treat 25 patients with an SGLT2 inhibitor instead of metformin for 3 years to prevent one additional MAC event. Common trap: confusing relative risk reduction with absolute risk reduction. Relative risk reduction here is 4 sin 12 to 30%. That sounds more impressive but is less clinically useful than NNT. NNT always uses absolute risk reduction. Read the command. Which deficiency explains the elevated INR? Terminal ileum resection, fat malabsorption, steatorrhea, elevated INR, fat-soluble vitamin deficiency affecting coagulation. INR measures the extrinsic pathway, factors 2, VI, IX, X, and proteins, C and S. All of these are vitamin K dependent clotting factors. The liver synthesizes them as inactive precursors. Vitamin K carboxylates glutamate residues to allow calcium binding and activation. Terminal ileum resection reduces absorption of fat-soluble vitamins A, D, E, K because bile salts are reabsorbed there. Steatorrhea means fat, and fat-soluble vitamins are lost in stool. The result, vitamin K deficiency, impaired carboxylation, elevated INR. Night blindness confirms vitamin A loss, but vitamin A does not affect INR. MCV 102-FL macrocytosis points to B12 deficiency from terminal ileum resection, intrinsic factor, B12 absorption site, but B12 deficiency causes megaloblastic anemia, not coagulopathy. 2 separate deficiencies, 2 separate consequences. Read the command. Most likely diagnosis: conjugated direct hyperbilirubinemia, acolic stools, dark urine at 4 weeks, obstruction of bile flow. Direct conjugated hyperbilirubinemia in a newborn is always pathological, never physiologic. Acholic stools mean bile cannot reach the intestine. Dark urine means conjugated bilirubin is being excreted in urine. It is water soluble. The biopsy showing bile duct proliferation and periportal fibrosis is classic for biliary atresia, progressive fibroinflammatory destruction of the extrahepatic bile ducts. It is the most common cause of surgical jaundice in infants and the leading indication for pediatric liver transplant. Kasa procedure potoitorostomai must be performed before 8 weeks of age for best outcome. Krigler, Najjar, and Gilbert are iron direct hyperbilirubinemia. Defects in UGT1A1 cannot conjugate bilirubin. Dubin-Johnson is direct hyperbilirubinemia, but benign, no liver damage, no acolic stools. Neonatal hepatitis can cause direct hyperbili but would show viral inclusions or hepatocellular damage, not bile duct proliferation. Read the command, most appropriate treatment, bacterial meningitis, gram-positive diplococci, strep pneumoniae, pregnant patient. Important nuance. Gram-positive diplococci in CSF and bacterial meningitis is Streptococcus pneumoniae. Standard treatment is vancomycin plus ceftriaxone for PCN. Resistant coverage plus dexamethasone reduces inflammation, decreases risk of sensorineural hearing loss. But this patient is pregnant. Pregnant women and elderly patients are at increased risk for Listeria monocytogenes, meningitis. Listeria is intrinsically risk for Listeria monocytogenes, meningitis. Listeria is intrinsically resistant to cephalosporins R for PCN. Therefore, in pregnant women with bacterial meningitis, ampicillin must be added to cover Listeria, even if the gram stain shows dipococci, because the gram stain may be negative for Listeria or results may be preliminary. The correct empiric regimen is ampicillin plus ceftriaxone plus dexamethasone, covering both S, pneumo, and Listeria. Choice C, vancomycin plus ceftriaxone plus dexamethasone, is correct for non-pregnant adults. In pregnancy, vancomycin is not the additional drug needed, ampicillin is. This question specifically tests the Listeria coverage exception. Read the command, mechanism of resistance. EGFR, mutated NSCLC, osimertinib, T790M, resistance mutation, classic acquired resistance to EGFR TKIs. EGFR TKIs, erlotinib, gefitinib, osimertinib, compete with ATP for binding in the EGFR kinase domain. The T790M mutation substitutes methionine for threonine at position 790, the gatekeeper residue. This substitution increases the binding affinity of the kinase domain for ATP. Because the drug must compete with ATP, higher ATP affinity means the drug is effectively displaced. The kinase remains active and downstream signaling continues despite drug presence. Osimertinib, a third-generation TKI, was actually designed to overcome T790M resistance, but secondary mutations C797ers can then emerge against osimertinib itself. Choices A, C, D, and E represent real mechanisms of acquired resistance to EGFR, TKIs. They are all legitimate resistance pathways. But the question specifically asks about the T790M mutation mechanism, which is uniquely the ATP binding affinity change. Read the command, mechanism of bone marrow suppression, methotrexate, macrocytosis, pancytopenia, folate supplementation given but not fully protective. Methotrexate is a folate analog that competitively inhibits dihydrofolate reductase, DHFR. DHFR converts dihydrofolate to tetrahydrofolate, THF. THF is required for 1-carbon transfer reactions, including synthesis of thymidylate, DTMP, and purines. Without THF, cells cannot synthesize DNA precursors. Rapidly dividing cells, DNA precursors, rapidly dividing cells, bone marrow, GI epithelium are most affected. Macrocytosis develops because cells grow but cannot divide, impaired DNA synthesis, normal RNA and protein synthesis. Folate supplementation helps prevent some toxicity but may not be sufficient at higher doses because methotrexate binds DHFR with much higher affinity than folate itself. Choice A, DNA alkylation, is cyclophosphamide and platinum agents. Choice C, fraudulent nucleotide, is 5-fluorouracil, 5-FIFU, or cytarabine. Choice D, thymidylate synthase inhibition, is also 5-fuse mechanism but independent of DHFR. Methotrexate's primary mechanism is DHFR inhibition, upstream of thymidylate synthase. Read the command. Underlying genetic defect, absent B cells, panhypogammaglobulinemia, recurrent encapsulated bacterial infections, normal T cells, X-linked pattern, brother affected, male patient, X-linked agammaglobulinemia, Bruton disease. X-linked agammaglobulinemia is caused by mutations in Bruton's tyrosine kinase, BTK. BTK is essential for pre-B cell receptor signaling during B cell maturation in the bone marrow. Without BTK, B cell development arrests at the pro-B to pre-B cell transition. The result, absent circulating B cells, absent plasma cells, profoundly low all immunoglobulin classes. Infections begin after maternal antibody wanes at around 6 months of age. Susceptibility is to encapsulated bacteria, opsinin-dependent killing, and enteroviruses. Choice A, ADA deficiency, causes CysD, both T and B cells absent. Choice D, RAG1 to RAG2, also causes CysDE, arrests VDJ recombination, affects both T and B cells. Choice E, IL-2 rod chain, is X-linked SCID-D, T cells absent, B cells present, but dysfunctional. The question specifies normal T cells, eliminates all SCID variants. Read the command. Immunopathogenic mechanism. Hypothyroid. Elevated anti-TPO antibodies. Lymphocytic infiltrate with germinal centers. Hürthle cell change. Hashimoto thyroiditis. Hashimoto thyroiditis is an autoimmune disease involving both humoral and cellular immunity. Anti-TPO and anti-thyroglobular cells, killing of thyroid follicular cells, hypersensitivity, and recruit NK cells via ADCC, antibody-dependent cellular cytotoxicity. Simultaneously, CD4 plus the cell toxic T cell killing of thyroid follicular cells, cytotoxic T cell killing of thyroid follicular cells. The dense lymphocytic infiltrate with germinal center formation confirms active antibody production and B cell activation within the gland. Hürthle cells represent a metaplastic response of injured follicular epithelium. Mitochondria, rich oxyphilic cells. Type IB alone, choice D, is an oversimplification. Hashimoto involves both antibody-mediated type 2 and cell-mediated type IB components. The anti-TPO antibodies are the serologic hallmark and the primary diagnostic marker, making type 2 the most accurate single answer. Block 2 is done. Let's review the 5 biggest traps from this block. Trap 1. In primary hyperaldosteronism, aldosterone is elevated. Sodium reabsorption is increased and potassium is wasted. Distractors that flip the direction of aldosterone's effect are designed to catch you if you are not reading carefully. Trap 2. Rheumatic fever is type 2. Molecular mimicry between streptococcal M protein and cardiac myosin. Post-streptococcal glomerulonephritis is type 2. Immune complex deposition. Same organism, different immunologic mechanism, different target organ. Trap 3. Bacterial meningitis in a pregnant patient requires ampicillin for listeria coverage. Listeria is resistant to cephalosporins. This is the single word that changes the entire antibiotic regimen. Pregnant. Trap 4. N&T calculation. Always use absolute risk reduction, not relative risk reduction. The exam frequently presents relative numbers that look more dramatic. Use 1 divided by the absolute difference. Trap 5. In a newborn with direct hyperbilirubinemia and colic stools, the answer is biliary atresia. Krigler, Najjar, and Gilbert cause indirect hyperbilirubinemia. Dubin-Johnson causes direct but is benign and does not cause colic stools. Terrain process, non-memorization. 20 questions, 5 major traps. Each one you recognize today is one you will not fall for on exam day. StepLogic. Learn how to think, not memorize.